Hi everyone, welcome back to PodBites, where we break down complex medical topics into bite-sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. Today, we're doing our outreach episode. I'm Jude Jimjoom, and I'm joined by my co-head, Sidra Jazia.
Hi everyone, this is Sidra speaking. Welcome again. I have to be honest, I'm a little bit stressed out about today's episode. Not because it's confusing, but because it really makes you realize how powerful stress can be and how deeply it can affect the brain.
That's actually a really good point. It's crazy how two people can go through the exact same stressful event, but only one of them continues to feel its effects long after it's over. And what's really interesting is the difference isn't the event itself, it's how the brain processes and responds to that stress. Sometimes the brain recognizes that the danger has passed, but other times it stays in survival mode, even when the person is safe.
Exactly. And that's what makes trauma and stress related disorders so important to understand. Because these conditions aren't about weakness or overreaction, they're about how the brain's survival system is designed to protect us. And sometimes that system struggles to switch off after a traumatic event, causing symptoms that can affect a person's thoughts, emotions, and daily life.
So let's get into it.
The brain's number one priority is survival. Before it cares about logic, emotions, or productivity, it cares about keeping you alive. There's a part of the brain called the midbrain, often referred to as the survival brain. Its job is to constantly monitor your environment and protect you from danger. It controls things like heart rate, breathing, and immediate threat responses, and it does so unconsciously.
So basically, it's like an automatic security system running in the background?
Exactly. Think of it like your phone's emergency mode. When your battery is low, your phone shuts off unnecessary apps and focuses only on survival. Your brain does the exact same thing during trauma. When danger happens, the brain activates the fight or flight response, which prepares your body to either escape or defend itself.
And this happens before you even have time to think, right?
Yes, the survival brain reacts faster than the thinking brain. For example, imagine you see a snake. You jump instantly. You don't stop and think, based on its anatomical characteristics, this appears to be a reptile. No, you jump first and then think later. That's your survival brain protecting you.
Okay, if that's the survival brain, what's the thinking brain?
The thinking brain is mainly the prefrontal cortex. This is responsible for decision making, planning, emotional regulation, focus, and logical reasoning. It's basically the CEO of your brain, and it keeps everything organized and rational.
So normally the CEO is in control. But what happens during trauma?
Well, during trauma, the CEO just flees the building. It helps to imagine it like a dimmer switch. The thinking brain turns down while the survival brain turns up. So instead of calmly analyzing the situation, the brain focuses on reacting quickly to protect you.
That explains why trauma patients often say things like, I wasn't thinking clearly.
Precisely, because literally the thinking brain is not fully active. The brain prioritizes survival over logic.
Okay, so survival mode is useful in danger, but trauma disorders happen when survival mode stays longer than it should, right?
Exactly. Survival mode is supposed to turn off after the danger passes, but in trauma disorders, the brain gets stuck in survival mode. This causes symptoms like number 1, difficulty concentrating, number 2, memory problems, number 3, fatigue, number 4, forgetting to care for basic needs, number 5, emotional reactivity, number 6, impulsivity, number 7, social withdrawal, and finally, number 8, feeling disconnected from life.
That's powerful. It shows trauma affects every part of a person's life.
Yes, and here's an important mindset shift. Behaviors like worrying, checking, avoiding, or withdrawal are actually the brain trying to protect itself, even if those behaviors become maladaptive. So the brain isn't broken per se, it's overprotective.
Let's apply this clinically. Imagine a 28-year-old man survives a severe car accident. Physically, he's fine, but afterward, he develops nightmares, avoids driving, feels anxious around roads, and jumps when he hears loud noises. What's happening in his brain?
His survival brain is still active. Even though the danger is gone, the brain hasn't turned off the alarm. This is the foundation of PTSD, or post traumatic stress disorder.
So let's define PTSD clearly.
Post traumatic stress disorder occurs after exposure to severe trauma, such as war, assault, accidents, disasters, or any life threatening events. The key feature is persistent activation of the survival system, even after the trauma ends. And here's a very high yield point. Symptoms must last more than 1 month for PTSD diagnosis. If the symptoms last any less than a month, it's called acute stress disorder.
So let's say a patient develops flashbacks and nightmares 2 weeks after the trauma. Would we consider this PTSD?
No, we wouldn't. We'd consider this as acute stress disorder because PTSD requires symptoms to last longer than 1 month. If you see 2 weeks on an exam, do not pick PTSD.
Got it. And you know what else is fascinating? Why do trauma memories feel like they're happening again even years later?
The answer is the amygdala. The amygdala is the brain's emotional alarm system. It detects danger and stores emotional memories, especially the traumatic ones. In PTSD, the amygdala becomes hyperactive. Even harmless triggers like sounds, smells, or places activate the alarm. Traumatic memories stored in the amygdala can feel as fresh after 20 years as they did on the first day.
So, in a way, the brain is reacting as if the trauma is still happening in the present?
Yes, the system itself is not broken, it's doing its job, but it's become overly sensitive, reacting to things that aren't actually dangerous.
Okay, this next part is important. What are the main PTSD symptom clusters that we need to know? And how can we remember them clearly?
This is extremely high yield, so buckle up. PTSD symptoms are grouped into 3 main clusters, and the easiest way to remember them is to think of a brain that is stuck in trauma. It keeps reliving it, tries to avoid it, and stays constantly on alert. The first cluster is re-experiencing. This is when the brain keeps replaying the traumatic event, even though it's over. Patients may have flashbacks, which feel like the event is still happening again, nightmares that are usually related to the trauma, and intrusive memories that enter their mind unexpectedly.
So, flashbacks, nightmares, and intrusive memories?
Exactly. Now, the second cluster is avoidance and numbing. Here, the brain tries to protect the person by avoiding anything associated with the trauma. This can include avoiding certain people, places, or situations. Patients may also withdraw socially, lose interest in activities they used to enjoy, and develop emotional detachment. Sometimes they appear emotionally restricted, what we often describe as to having a poker face, where they do not express emotions like they used to.
Okay, to put what Seed said in 3 words, there's avoiding, social withdrawal, and emotional detachment.
Well said, Jumi! The third cluster is hyperarousal, which means the brain remains in survival mode. Patients become hypervigilant, meaning they're constantly scanning for danger. They may feel irritable, have difficulty concentrating, and show an exaggerated startle response, like jumping easily at sudden sounds.
Essentially, the brain is stuck in 3 states. It keeps reliving the trauma, tries to avoid reminders of it, and stays constantly alert for danger.
Yes, just remember that PTSD is a brain that cannot move on. It keeps re-experiencing, it keeps avoiding, and it stays hyper-aroused. Relieve, avoid, alert. If you remember those 3, you'll recognize PTSD instantly in any clinical scenario.
That raises an important question. If trauma activates the brain's alarm system, why doesn't everyone who experiences trauma develop PTSD?
Because of the hippocampus. The hippocampus plays a key role in regulating emotional responses and helping the brain calm down after a traumatic event. To understand this, remember that the brain has 2 important structures involved in trauma: the amygdala and the hippocampus. The amygdala acts like an emotional alarm. It stores intense emotional memories and activates fear responses, whereas the hippocampus helps regulate and calm these emotional responses. You can think of it as trying to extinguish the emotional fire created by the amygdala.
So the amygdala starts the alarm and the hippocampus tells it to calm down.
Exactly. If someone has a strong and healthy hippocampus, it can reduce the emotional intensity of the memories and help the brain recognize that the danger is over. But if the hippocampus is smaller, weaker, or less active, it becomes harder for the brain to regulate the amygdala. As a result, the emotional memory stays intense, and the person becomes more vulnerable to developing PTSD. That's why the impact of trauma does not depend only on the event itself. It also depends on how effectively the hippocampus can regulate the amygdala.
So people with a stronger hippocampus are better able to recover from trauma.
Yes, a stronger hippocampus helps reduce emotional intensity and allows the brain to move on more effectively. But a smaller hippocampus increases the risk of developing more severe and persistent PTSD symptoms. And interestingly, the hippocampus is also closely linked to depression. Depression can cause the hippocampus to shrink, which further reduces its ability to regulate emotional responses. The good news is that the hippocampus can also recover and grow. Things like good sleep, exercise, enriched environments, and antidepressants treatments help support the hippocampal health and improve emotional regulation.
So far, we've been talking about PTSD as a response to a traumatic event. But is PTSD always caused by just one single event?
Not necessarily. There's a subtype called complex PTSD, or CPTSD for short. Unlike regular PTSD, which usually happens after a single traumatic event, complex PTSD develops after prolonged repeated trauma, especially over months or years.
So this would be more like chronic exposure to trauma rather than a one-time event?
Yes. Examples include growing up in a neglectful or abusive household, experiencing long-term abuse during childhood, or living in war zones where the stress and fear are constant. Because this trauma happens during critical developmental periods, it affects not just fear responses, but also the person's identity, emotional regulation, and relationships.
And do the events go deeper than regular PTSD?
Unfortunately, they do. Patients with complex PTSD often live in a constant state of fear and insecurity. They may have a fragile sense of self, meaning even small criticism can feel devastating. They often struggle with low self-esteem, emotional instability, anger, chronic depression, and difficulty forming relationships. Some patients may suddenly cry without a clear reason, or feel extremely sensitive to stress and criticism. It's like their emotional system never had the chance to develop a stable foundation.
That makes sense. But the brain also tries to protect itself, right? What are some defense mechanisms people use to cope with trauma?
One of the most important defense mechanisms is compartmentalization.
What does that mean?
Compartmentalization is a psychological strategy where traumatic events are placed in compartments in the brain so they don't interfere with daily functioning.
Okay, so how does putting things in compartments help?
Think of it as having separate folders on your computer. One folder contains your daily life, and another folder contains traumatic memories. This allows the person to function normally without constantly reliving the trauma. And this can actually be healthy when used properly because it can help protect the thinking brain from being overwhelmed.
But can it ever be unhealthy?
Of course it can. Did you never watch that one SpongeBob episode where the files are all going haywire?
You mean this one?
Exactly that one. It becomes unhealthy when the brain uses compartmentalization to separate conflicting behaviors instead of processing them. For example, someone might do something wrong, like steal, but still pray regularly and see themselves as a good person. Their brain keeps these actions in separate mental compartments, so one doesn't interfere with how they see themselves in other situations. It's like the brain is saying, these two things do not interact, even though logically they should.
So the brain is protecting itself from emotional conflict by keeping those experiences separate?
Precisely. And while compartmentalization can help protect someone from being overwhelmed by trauma, it can become harmful if it prevents them from fully processing their experiences or recognizing contradictions in their behavior. That's why, in therapy, the goal is to teach patients how to compartmentalize in a healthy way to help them manage traumatic memories without letting those memories take over their daily lives. At the same time, therapists work to prevent unhealthy compartmentalization, which would otherwise allow contradictory or harmful behaviors to continue without emotional awareness or resolution.
So healthy compartmentalization helps someone cope and function, but unhealthy compartmentalization prevents emotional healing.
Yep. The goal is to help the brain process trauma safely, not avoid it completely.
Another defense mechanism is reaction formation. What exactly is that?
Reaction formation is when someone expresses the opposite of how they actually feel. For example, someone who feels deeply hurt or scared might laugh or joke instead.
So the brain hides the real emotion by expressing the opposite?
Think about when something stressful happens and someone makes jokes about it instead of showing fear. It's the brain's way of protecting itself from emotional pain.
Now let's talk about treatment. If PTSD is caused by an overactive survival system, how do we help patients recover?
Treatment focuses on retaining the brain and calming the overactive fear system. One of the most important treatments is cognitive behavioral therapy, or CBT. This helps patients develop healthier coping strategies and reduce the emotional impact of trauma. Another approach is prolonged exposure therapy, where patients gradually confront their traumatic memories in a safe environment. Over time, this reduces the emotional intensity of those memories.
So instead of avoiding the trauma, they slowly face it in a controlled way.
Yes, this helps the brain learn that the trauma is no longer a present danger. There's also a therapy called eye movement desensitization and reprocessing, or EMDR for short. This involves focusing on a visual stimulus while processing traumatic memories, which may help reduce their emotional intensity.
And what about medications?
Medications like antidepressants and antipsychotics can help regulate brain activity, especially by reducing the amygdala's overreactivity. This helps the brain feel safer and reduces symptoms like anxiety, fear, and emotional distress.
So in PTSD, the brain is stuck in survival mode because of trauma. But sometimes the brain gets stuck in a different kind of loop. Not from trauma, but from anxiety itself.
Instead of reliving the trauma, the brain gets trapped in repetitive thoughts and behaviors. It's like your brain becomes that one friend who keeps asking, "Are you sure you locked the door? Are you really sure? Maybe you should just check one more time." And that brings us to obsessive compulsive disorder, or OCD for short. It's a chronic psychiatric disorder characterized by two core components: obsessions and compulsions.
But seeds, what does this actually look like in real life? How severe can OCD become?
Let me tell you about a clinical example. Adam was a university student who struggled every morning before leaving his apartment. Before going out, he would lock his door like anyone else normally would, but almost immediately, a thought would enter his head. What if I didn't lock it properly? Even though he clearly remembers locking it, the doubt did not just go away, so he would check the door again, and then he'd walk away, but then the anxiety would return. What if I just imagined locking it? So he'd go back again, and check all over again. This would happen over and over, sometimes 10 or 15 times, until he was already late for class.
So the obsession was an intrusive doubt, like, what if I didn't lock the door? And the compulsion was repeatedly going back to check the door to reduce that anxiety.
You're absolutely right. And even though checking helped temporarily, the relief never really lasted long. The next day, the cycle starts all over again. Over time, this began affecting his academic performance, his daily routine, and his quality of life. He wasn't checking because he wanted to. He was checking because his brain would not let him feel calm until he did so.
So OCD isn't about being careful, it's about being trapped in a cycle of anxiety and temporary relief.
Well said, Jumi. And that's the key concept to remember. Obsessions create anxiety. Compulsions temporarily relieve that anxiety, but they reinforce the cycle and make it stronger over time.
I remember something called ego dystonic. What does that mean?
Ooh, that's a very important point. Ego dystonic means that the patients are aware that the thoughts are irrational and they don't generally want them, but they cannot control them. They hate the thoughts, they do not enjoy them, but they're forced by anxiety.
Okay, let's talk about Adam's case, because honestly, this case shows exactly how OCD can take over someone's life.
Adam lived only 30 minutes away from his university, but it took him nearly 4 hours just to leave his apartment. What should have taken 5 seconds took him nearly an hour.
That sounds exhausting just to hear.
Yeah, OCD is not just about anxiety. It's time-consuming and function-impairing. The DSM criteria requires that the symptoms consume more than 1 hour per day, or significantly impair social, occupational, and daily functioning.
So, what are the most common obsessions and compulsions?
The most common obsessions include repeated fears of contamination, such as worrying about germs from touching objects or public surfaces. There is also repeated doubt, like constantly worrying that the door was not locked or the lights were left on. Some patients also have an intense need for symmetry and order, which is the fourth most common, where objects must be arranged perfectly. Even small misalignments can cause severe distress. As for compulsions, the most common one is excessive hand washing, especially in females, sometimes to the point that the skin becomes raw and damaged. Other common compulsions include repeatedly checking doors or locks, especially in males. There is also excessive cleaning of objects or surfaces, counting things over and over, arranging items repeatedly, and constantly seeking reassurance from others.
So, being familiar with these patterns help us recognize OCD when we see it in a clinical case.
Yes, these types of repetitive thoughts and behaviors are the classic clues that point toward OCDs. If someone just alphabetizes their spice rack once, that's just a personality quirk. But if they alphabetize it 47 times at 3 in the morning and cry if paprika is misplaced, that's OCD.
That really puts it into perspective. It's not just about the behavior itself, but how much control the behavior has over the person.
The behavior starts controlling the person instead of the person controlling the behavior. OCD usually begins in adolescence or early adulthood.
Okay, now let's talk about the brain mechanism behind OCD.
OCD involves dysfunction in a brain circuit called the CSTC circuit. This stands for cortico-striato-thalamo-cortical loop. Normally, this circuit allows the brain to initiate and stop actions. But in OCD, this circuit malfunctions. The brain fails to recognize that the action is complete, so it keeps repeating the action over and over again.
And what about the brain anatomically? If we performed a brain activity scan, what would we see?
On brain activity scans, specifically PET scans, we would see increased glucose metabolism in the orbitofrontal cortex and the basal ganglia. This means that those brain regions are overactive. The orbitofrontal cortex is responsible for decision making and detecting when something feels wrong. The basal ganglia helps regulate and stop repetitive behaviors. In OCD, both of these areas become overactive and keep signaling that something is incomplete or safe. So even when the person locks the door, the brain does not register that the task is finished.
Pretty much, the brain is stuck in overdrive.
Exactly. The orbitofrontal cortex keeps sending warning signals, and the basal ganglia fails to shut off the loop. This leads to repetitive thoughts and compulsive behaviors.
That explains the brain circuit and the basal ganglia involvement. But what actually causes OCD in the first place? And why do some people develop it?
OCD has several causes, and one of the most important ones are genetic factors. Specifically, OCD is linked to a mutation in the serotonin transporter gene, called HSERT. This transporter normally helps regulate serotonin levels in the brain. When this system does not function properly, serotonin signaling becomes dysregulated, and since serotonin plays a key role in regulating mood, anxiety, and behaviors, this contributes to the repetitive thoughts and compulsions seen in OCD.
So, this also explains why SSRIs are used as a treatment, because they target serotonin.
Another important cause is autoimmune related OCD, especially in children. This condition is called PANDAS, which stands for Pediatric Autoimmune Neuropsychiatric Disorder, associated with a streptococcal infection. In this condition, a streptococcal infection triggers an immune response. The immune system mistakenly targets parts of the brain, especially the basal ganglia. This leads to inflammation and dysfunction in the basal ganglia, which then causes sudden onset OCD symptoms.
So, the immune system accidentally damages the same brain region involved in OCD behavior control.
Yes, and this is very important because unlike typical OCD, PANDAS is treated differently. Instead of just psychiatric medication, treatment may include antibiotics to eliminate the streptococcal infection, and sometimes plasmapheresis to remove the harmful immune components.
Affirmatively, OCD isn't just caused by one factor. It can involve genetics, brain circuitry, immune system dysfunction, and environmental influences.
Yeah, but the key structure involved in all cases is the basal ganglia, which plays a central role in regulating and stopping repetitive behaviors.
How do we actually help patients break free from that cycle?
Well, the good news is that OCD is very treatable, and the treatment focuses on helping the brain unlearn that it doesn't need to respond to every single intrusive thought. One of the most important treatments is behavioral therapy, specifically a technique called exposure and response prevention, or ERP for short.
Exposure and response prevention? Is that like exposure therapy?
Kind of, yes. It means gradually exposing the patient to the triggers that cause the anxiety, but teaching them to resist performing the compulsion. For example, if a patient fears contamination, the therapist might have them touch an object they normally would avoid, but then guide them not to wash their hands immediately afterwards. At first, the anxiety increases, but over time, the brain learns something very important, that nothing bad happens, even without the compulsion. This helps retain the brain and weaken the obsession compulsion loop.
So instead of obeying the compulsion, The patient learns to tolerate the anxiety until it naturally fades.
Yes, this helps the brain regain control. In addition to behavioral therapy, medications are also very effective. The first line medications are SSRIs, short for selective serotonin reuptake inhibitors. These include drugs like fluoxetine and sertraline. They work by increasing serotonin levels in the brain, which helps regulate the overactive circuits involved in OCD.
And what if SSRIs don't work?
The second line medication is clomipramine, which is a tricyclic antidepressant that also targets serotonin.
So, behavioral therapy and SSRIs are the main treatments. But what happens in severe cases when the patient doesn't respond to therapy or medications?
In rare and extreme cases where OCD is severe and refractory to treatment, we may consider a surgical procedure called an anterior cingulotomy. This procedure involves interrupting the abnormal brain circuit between the frontal lobe and the basal ganglia, which is responsible for the repetitive thoughts and compulsive behaviors.
Wait, surgery? Do we actually perform brain surgery for OCD? That sounds like a major step.
It is. That's why anterior cingulotomy is only used in severe treatment-resistant OCD. And very interestingly, studies have shown that this procedure can improve symptoms in up to 50% of patients.
50%? That's actually impressive.
Yep. By interrupting the abnormal brain circuit, it helps reduce compulsive behaviors. But it's always a last resort because it's pretty invasive. And most patients improve with exposure and response prevention therapy and SSRIs anyway.
That's reassuring. I do have a question though. Once OCD develops, does it eventually go away? Or is it something patients live with long term?
OCD often follows a chronic course. Many patients experience what we call a waxing and waning pattern, where symptoms improve for a period of time and then just worsen again. In a small percentage of patients, about 5%, OCD may occur in episodes with minimal or no symptoms between the episodes. However, without proper treatment, OCD can gradually interfere with a person's daily functioning, including their work, studies, and even relationships.
So over time, it can start affecting multiple areas of life.
Unfortunately, yes. But the good news is that prognosis is generally very favorable with proper treatment. About 90% of patients experience moderate to marked improvements when they receive optimal treatment, including behavioral therapy and medications.
That's actually very encouraging to hear.
It is. And outcomes are even better when patients are motivated, consistent with treatment, and actively participate in therapy. Family support also plays a major role in helping patients stay on track. With the right treatment and support, many patients are able to function well and live productive, fulfilling lives.
What's the difference between obsessive compulsive disorder and obsessive compulsive personality disorder, or OCPD for short?
That's a very tricky one. OCD is ego dystonic. The patient hates the thoughts, while OCPD is ego syntonic. The patient likes the behavior. OCPD is perfectionism. These people like doing what they do, and they believe it's the right thing to do. On the other hand, OCD is an anxiety-driven compulsion. The patients hate doing them, but they feel the need to out of fear.
Thank you for clarifying that, Sidra. Now let's move on to another topic. You know, I think most of us have had moments where we look in the mirror and notice something small, maybe a pimple, or our hair isn't sitting right, and it bothers us more than it probably should. And for most people, that feeling passes quickly. They move on with their day. But for some individuals, that concern doesn't go away. It becomes overwhelming. It takes over how they see themselves and how they live their lives. This is body dysmorphic disorder.
Body dysmorphic disorder, or BDD for short, is another condition to be aware of. It's when a person becomes excessively preoccupied with a perceived flaw in their appearance, even though, objectively, they look completely normal. The flaw may be very minor, or may not exist at all, but the patient experiences it as severe and distressing. Many of these patients become deeply dissatisfied with specific facial features, such as their nose, cheeks, lips, or even their skin.
So even though others see themselves as normal, they genuinely believe something is wrong with their appearance?
Yes, and because of this belief, many patients repeatedly visit plastic surgeons, hoping that surgery will fix the perceived defect. They may spend large sums of money on cosmetic procedures, But even after the surgery, they often remain dissatisfied because the problem isn't the physical feature, it's how the brain perceives it. This persistent dissatisfaction with their appearance is a defining feature of body dysmorphic disorder.
So surgery doesn't actually solve the problem because the issue originates in the brain.
And this constant distress can be overwhelming. That's why this disorder is associated with a very high risk of suicide. Recognizing this condition early is critical because these patients are suffering deeply, even if it's not visible to others.
Wow, high suicide risk? That really shows how serious and distressing this condition can be.
Also, body dysmorphic disorder is part of the same spectrum as OCD. Both involve intrusive thoughts and repetitive mental focus. But in BDD, the focus is specifically on perceived appearance flaws.
And what is it called when someone repeatedly pulls out their own hair during exam period?
Trichotillomania. Trichotillomania is a condition where patients repeatedly pull on their own hair, often from the scalp, eyebrows, or eyelashes.
Is this also related to OCD?
Yes. This behavior is usually driven by anxiety or internal tension, and pulling the hair provides temporary relief. Like OCD and body dysmorphic disorder, trichotillomania is part of the same spectrum of disorders involving repetitive behaviors and difficulty controlling the impulses.
So even though the behaviors are different, the underlying pattern is similar. The brain gets stuck in a cycle of distress and repetitive action.
Right. These conditions all involve dysfunction in the brain circuits responsible for regulating thoughts, impulses, and behaviors.
There's one last critical point we need to remember when talking about these disorders: the risk of suicide. What's the most important predictor we should recognize?
The strongest predictor of suicide risk is hopelessness. Not depression severity, not anxiety severity, but hopelessness.
So it's not just about how much someone is struggling. It's about whether they feel there's a way forward.
Exactly. When someone still has hope, even during difficult times, they can keep going. But when a person feels completely hopeless, when they believe nothing will ever improve, that's when the risk is highest. And that's why recognizing hopelessness and providing support can truly save lives.
All right, we've reached the end of this episode. Sidra, can you give us a quick recap?
Of course. We started by understanding how trauma affects the brain. Trauma activates the survival system, especially the amygdala, which stores emotional memories. When the brain cannot properly calm down this response, often to reduced regulation from the hippocampus and prefrontal cortex, it can lead to PTSD.
And PTSD is characterized by three main symptom clusters: re-experiencing the trauma, avoidance of reminders, and hyperarousal.
We also discussed complex PTSD, which develops after prolonged or repeated trauma and can affect emotional stability, relationships, and self-identity.
Then we moved on to OCD, where the brain gets trapped in a loop of intrusive thoughts, called obsessions, as well as repetitive behaviors, called compulsions.
This happens because of dysfunction in the CSTC circuit, especially involving the basal ganglia, the orbitofrontal cortex, and neurotransmitters like serotonin. Brain scans show increased activity in these regions.
And the treatment focuses on breaking that cycle with exposure and response prevention therapy and medications like SSRIs, while surgery is reserved for only severe treatment-resistant cases.
We also covered related disorders like body dysmorphic disorder, where patients are preoccupied with perceived appearance flaws, as well as trichotillomania, where patients repeatedly pull their hair due to anxiety.
And finally, one of the most important clinical points is that the strongest predictor of suicide risk is hopelessness.
Exactly, because when hope is lost, the brain struggles to see a way forward.
Understanding these conditions help us recognize them early, support patients effectively, and ultimately help them regain control over their lives.
I think that wraps up today's episode. Thank you for having me, and hopefully your CSTC circuit will stop forcing you to re-listen to this episode 37 times.
No promises. Thank you everyone for listening to PodBites. Until next time, Seeds and Jumi out.